severe risk. And so these things, the individual has to understand what those things are. And so what I'm going to give you examples for is just how that looks, why we think we can begin to develop strategies that align better to the individual around and try to address some of the issues that are barriers to the prevention early detection strategies we have now. So here's just one example I think you're probably all very well familiar with. This is cigarette smoking and lung cancer. So this is the signature success story in many ways of prevention and in fact early detection. So as you know, prior to 1900, lung cancer was a very rare disease, almost didn't exist around the world. But after the Industrial Revolution and after cigarette smoking became really popular in World War I, cigarette smoking started taking off. And about 20 years later, lung cancer started becoming more common. So this blue line is smoking, and this gold line is is lung cancer. And so you can see that over time, a number of social and economic things happened that made cigarette smoking very popular, and as a result made lung cancer very prevalent. But in the 1960s, the Surgeon General report, the bans of cigarette smoking and smoking advertising, bans of smoking in public places, etc., made cigarette smoking drop, and as a result, now we're seeing drops in lung cancer. Still the most common cause of cancer death in the United States, in the world, but you can see this, the issue of the population approach that I was describing before, where you can achieve important population interventions that result in declines in cancer incidence and death. But there's a 20-year lag. There are a lot of things that make it difficult for people to stop smoking. I was to tell this room any of that, but the population approach works, but it's imperfect and difficult to achieve. The other thing that we've had in the precision approach, or the motivate the precision approach, are examples like this in the CARROT study and some others, chemoprevention studies. This is an example from 1994, the first report of the CARROT study, effective beta-carotene on the incidence of lung cancer in male smokers. And as you know, this was a large trial, a large intervention study where beta-carotene, among other agents and this and other studies, were given to individuals who smoked. And based on epidemiological and the best basic science data that was available at the time, everybody said this is going to reduce the incidence of lung cancer among smokers. And to make a very long story short, what happened was that individuals who were in the beta-carotene arm had higher rates of lung cancer than those that were in the placebo arm. So completely opposite of what was expected. And
sorry, I'm having trouble with the connection.
Okay, I don't know. What did I do? So this was a problem, right? We gave an intervention to a large number of individuals, increased the rate of smoking, or increased the rate of lung cancer in the intervention arm. So not only was this a failure, and there were a number of other studies like this that were failures, but it became a huge barrier to mounting other studies like this. People were saying, well, we thought we knew what we were doing. We wouldn't have done a very, very large interventional study if we thought it was going to increase the rate of cancer in the intervention group. And so chemoprevention studies have been very difficult to mount and fund, and because of things like this. But the point I want to make is that some of this is due to our limited understanding of biology, or at least in limited understanding of biology at the time. Now we may be able to explain why giving beta-carotene to individuals who smoke is not necessarily beneficial, because we have a little bit better sense of how that drug interacts with individuals who are active smokers and causing DNA damage and other metabolic changes that may actually explain this. And I think had we had that basic biological knowledge and motivated this study around that biological knowledge, we may have been able to avoid this, either by defining the study differently, thinking about different interventions, etc. So this is, again, another piece of motivation for why a precision approach or a molecularly based approach might have benefit. So when we think about what precision prevention and early detection might mean, here's some basic points, basic concepts. The identification and use of biologically based mechanisms. to prevent or intercept cancer development, progression, and recurrence from metastases. So again, the focus on knowing something about the biological basis of the disease, the progression, the initiation, et cetera. And I would also argue that this prevention early detection really can be applied across the continuum of cancer, the whole spectrum. So we can imagine that we will be able to do primary prevention, prevent the occurrence of a tumor. We can detect the tumor early if we have better understanding about the biology. We can intercept, we can intervene, we can do something to limit the progression of that tumor to something that might be fatal. And even at the very end stages of cancer, we can monitor disease. We can use molecularly based strategies or biologically based strategies to monitor when someone is progressing with disease, when they might need a change in treatment, et cetera. So I think that even though we talk about prevention and early detection as something that seems to happen on the left-hand side of this slide, for the most part, primary, secondary, and tertiary prevention strategies really are relevant here, and that we can consider strategies that go across the entire continuum of carcinogenesis. So that's one point. And so what does it look like? This is going to be very conceptual and hypothetical now, but what might it look like in a population if you wanted to apply such a strategy? So let's just look at this cartoon. If the goal is to minimize harms from a preventive strategy and maximize benefits, we can think about on the x-axis here how efficacious, what the benefit is for this preventive strategy, whatever it might be, or this early detection strategy. And we can think on the y-axis about the toxicities, the harms that might come of this. And what you see is that there's some equipoise situation where toxicity and efficacy are equal to one another. And you see that there are some situations where the toxicity outweighs the efficacy, so the harms outweigh the benefits, and other situations where the harms are less than the benefits. And so you think about where in this space the intervention, the early detection strategy you might want to develop might lie. So let's just imagine there's a population of people. If you were to apply this intervention strategy, you might identify some efficacy. You might identify some toxicity, so some level of efficacy and some level of toxicity in the general population. In this case, this might be something that overall you would be quite happy about, because you do have some efficacy and the toxicities might be sufficiently low that you're okay with providing it to the general population, because the toxicity efficacy benefit ratio is favorable. But what we're really seeing in the population is that there are subpopulations of people. And there are some subpopulations of people who have, when given the preventive strategy, given this early detection approach, whatever, have very unacceptable levels of toxicity, and the efficacy is somewhat low. They really, in fact, fall down into the level where you wouldn't want to give this intervention to those individuals. There might be other individuals in the population where the toxicity remains fairly high, but the efficacy is also fairly high. And that might be a situation where it's acceptable if the risk is sufficiently high to the individual. So you can imagine the example of prophylactic oophorectomy in the BRCA1 mutation carrier. The efficacy is really high. You reduce your risk of ovarian cancer by quite a bit, but you have to remove your ovaries perhaps at a very young age, and that's not a non-toxic intervention. So there's toxicities. But again, if the alternative is to wait until you have invasive ovarian cancer, that it's not curable, maybe those toxicities are acceptable. So and I'll give you some more examples about what that looks like very specifically. And obviously what we're trying to do is achieve something down here. We're trying to identify individuals whose the efficacy for this intervention is very high and the toxicities are very low. And so what you're thinking about here is that there is a population out there, this general population, but not everyone is equal. Everybody might have a different ability to respond, may have different levels of toxicity, and our ability to identify who these people are and intervene in them in an optimal way is really important. And this is, again, to drive the point home again, it's really, really critical when we're talking about prevention. We're talking about something that we're trying to intervene in individuals who are healthy or may have low tolerance for toxicities or harm. These individuals are not going to accept something that has a high level of toxicity. Even though it might impact on their overall later risk, it's not going to work. It's not going to be implementable if the toxicities are too high, unless you're in a very unique situation. So let me give you 2 examples of what this might look like. Just 2 examples of where we are in thinking about precision prevention approaches. And these are just 2 examples that I'm using to illustrate the points that I've raised just now about how we might be able to use molecular knowledge and biology to motivate and implement better these strategies for risk and risk reduction. And I'm going to give 2 examples because I think they are sort of the high-level domains that most of us have been thinking about in terms of precision prevention strategies. And that is among genetically susceptible individuals and among individuals with preneoplasia. So these are both groups of individuals who are at increased risk, have some underpinning of biology that we understand, hopefully, that we can use to better develop and implement prevention and early detection strategies, so based around biology. So here's my first example. This is myeloma. We recently had a Stand Up to Cancer grant funded for a thing called the PROMISE study, where we're following 50,000 individuals forward. We're going to do a natural history study of disease among individuals who have monoclonal gammopathies of undetermined significance, or MGUS. These are individuals who have a precursor lesion, and we believe everybody who's had a myeloma has gone through the MGUS stage. But most people with an MGUS don't progress to myeloma. But when you do progress to myeloma right now, it's incurable. You might not die from it, you might be able to manage it for a long time, but you'll have it forever. And the mortality rate is really fairly high. So how do we begin to think about a precision prevention early detection initiative that accounts for someone with a precursor lesion for which we know a lot about biology in order to prevent them from having a bad outcome and dying from their cancer? So here's the progression along here from individuals with MGUS to smoldering myeloma, so actual myeloma but without all the clinical symptoms, actual malignant or multiple myeloma that has many clinical manifestations, to relapse and then death. So the progression of disease is fairly well understood. We also, in this picture, know a lot about the molecular events that occur along the progression from very early normal individuals to MGUS to myeloma. And so without going into a lot of detail about what these are, there are chromosomal abnormalities and other mutations that occur very early in the individuals who have MGUS. So we can screen for MGUS. It's a simple blood protein test, something that we can do very easily. And we can identify pretty cheaply the markers of, that might hallmark a poor prognosis or likelihood of advancing to a smoldering myeloma. And as you can also see, there are a lot of individuals or markers, mutations that are occurring throughout the course of the disease. And so what you can imagine is that you begin with an M spike, a screening for an abnormal protein that hallmarks an MGUS. When you see that person, you can begin to understand their underlying biological setting, whether they're on their way to developing smoldering myeloma, and you can monitor them on a regular basis for the occurrence, the development of new mutations, which might suggest progression. So you can use, for example, cell-free DNA and ultra-low-pass whole genome sequencing, something that is really kind of feasible now to identify very specific molecular mutations. There is the possibility, we're beginning to develop some tools, some very interesting new early detection tools that allow continuous monitoring, not just one blood draw, but allow for implants that can do continuous blood draw or blood monitoring for the occurrence of some of these new mutations with synthetic biomarkers that read out when these markers appear, and in fact, the markers concentrate in the urine, and you can do a simple urine test for the presence of these mutations. This is all aspirational, of course, but the notion that you can begin to, we know enough about biology that you can see when the disease is progressing molecularly. We also have treatments for myeloma. And what happens now is when you start having lytic lesions in your bone or organ damage, they start treating you. And so that's fine because there are treatments, but why should we wait until you have these horrible clinical manifestations before you start getting treated? Why can't we start thinking about treating people earlier before they have these things? And so there are drugs out there, elotuzumab, lenalidomide, dexamethasone, not non-toxic, simple kinds of drugs, but drugs that in an individual who has a series of molecular markers that hallmark progression to a malignant disease could be used in a certain setting. And now there are trials that are beginning to ask, can we reverse migrate? Can we take drugs that are chemotherapeutic agents, not non-toxic, they're toxic, but can we migrate them back in the progression of disease a little further so that based on a molecular signature and a continuous monitoring of the progression of their disease,